our next speakers, Dr. Rahul Modi, who is a consultant ENT surgeon, and Dr. Kinjal Modi, who is a consultant pulmonologist, to start sharing and discussing their views on sleep apnea.
Well, initially,
hello everyone.
This subject today is a combination by a pulmonologist and ENT surgeon related to sleep apnea. There was going to be a debate, but I think one after the other you will share your views on stage. We start with Dr. Rahul Modi.
Please have the video.
This is not a sound technical problem.
Yeah. Can everybody hear this? The background music. Yes, it's snoring. It's the sound of snoring, and many of have encountered this sound. So let's see the pathophysiology behind snoring from Dr.
Hello everyone. Hope all of you are doing well. My name is Dr. Rahul Modi. I am a consultant ENT and a head and neck surgeon practicing at the Nanavati Max Hospital. I have my own clinic in Malad. My special area of interest is management of obstructive sleep apnea. I'll be discussing the various aspects related to it at our upcoming BMB meeting. So looking forward to meeting all of you and interacting with all of you at SILVASSA. Cheers.
Hi everyone, a very good morning. Right. So after that interesting lecture by Dr. Ajani sir, I'm sure nobody is snoring in the audience right now. So we thought of taking up this topic for our audience here. To just create some awareness, I'm going to go through some very basic stuff about sleep apnea, and I'll be talking about the pathophysiology and the clinical presentation, and followed by that Dr. Kinjal will be talking about the treatment and the management, and we'll be happy to take the questions at the end of the session, and we'll be happy to answer any queries.
I think the technical system also has gone to sleep. And dropped it in the registration box kept at the registration counter, because the bumper prizes, as I already mentioned, there are plenty of them at the end of this show, at the end of the conference, and we are going well in time, so nothing to worry. Lunch will be served at the normal usual time, and before that, don't forget to collect your written gift. One more written gift, the red color bag sponsored by Aquamex was given to you yesterday. Today one more cello flask is going to be given to you. That will be given to you once you sign for the MMC registration at the end of the conference. So don't forget to collect that. Lunch, as usual, is going to be a lavish one, but requesting all of you who are going to travel by bus, kindly keep in mind the motion sickness because we don't have any doctors in the bus, all of them are in the leisure mode, or if at all you require help of a doctor, he or she may charge the double charge, right sir? So kindly control on the diet. Yes sir, ready?
Yeah, my apologies for the delay. My first time at the BMB, really excited to talk and interact with you guys. As I suggested, just talk on sleep apnea, small overview. So this event happened, the unfortunate event happened not so long ago. We lost a very dear music composer of ours, which really we had a lot of patients asking us what is this sleep apnea all about, and that just reinvigorated the interest in this. And what is is it really a rare problem, or is it that common? So this is the UK data, where we have about close to 20% of individuals between the age of 30 and 70, and that's the audience right here, right? We know the senior and the junior most colleagues here. 3 to 9% of the women in that age group. More than 80% undiagnosed. This is coming from a developed country like UK, and that is because there is very low awareness, not only in the public but also in the medical fraternity. So that is what I hope to change from today's talk. And why is it important to know about sleep apnea is because it's right there in our faces. I'm sure all busy practitioners here will be seeing at least 2 or 3 patients of sleep apnea every day in their clinic. That's an understatement. Some of you may be seeing close to 10 patients if you have a OPD exceeding 60, 70, and especially if you're seeing patients with sleep comorbidities such as drug-resistant hypertension, congestive heart failure, diabetes mellitus, and that is like your everyday patient in the clinic, right? So this is there. So what is exactly obstructive sleep apnea? So it's actually a very simple definition, and it is also known as a OSAS syndrome. It's part of the spectrum of what we call as a sleep disordered breathing, and it occurs when there are repeated episodes of complete or partial block in the upper airway during sleep. So what are you having? You are having this kind of a scenario where the person is sleeping with a normal open airway but ends up having a blocked airway during his sleep. And essentially you need to have an obstructive element which is occurring during sleep causing apneas. So the name itself is a definition. You need to have an obstructive sleep apnea. Now what exactly happens in that? Just a quick overview of the sleep cycle. We have 4 stages of sleep. There is a non-REM sleep, and then there is a REM sleep. I will not go too much into detail because I'm sure I'll put you off into one of those stages. But when you look at the sleep cycle in the night, what is important to understand is these things occur in a very uniform pattern. The stage 1 is followed by stage 2, followed by stage 3 and stage 4. Stage 3 and stage 4 together are known as the sleep or the slow wave sleep, and that is what is important for feeling physically refreshed. And the REM sleep, which occurs in the later of the sleep, is responsible for feeling mentally fresh. So physically fresh and mentally fresh, and that is why we recommend avoiding division of sleep time. So if you're sleeping 4 hours in the night and 4 hours in the afternoon, you will always get more of non-REM sleep, you will not get sufficient REM sleep, and you will not feel fresh mentally to do stuff. So, and this pattern changes with age. As the child grows up, there is a large amount of REM sleep to start, which reduces with age, and that is why elderly people find it difficult, and sometimes their sleep is not that as refreshing as it should be. Now, so far we have been focusing so much on the quantity of sleep. However, where sleep apnea hits is on the quality of sleep also. It significantly hits the quality of sleep, and why does that happen? So, quick question to all of us here. We know that snoring is a common problem. We all know family members who snore in our household. But that snorer will never snore during the day. That snorer will never snore in a supine position. So what is that happens that that person becomes such a loud nuisance for everybody in the household the minute he goes off to sleep, where a regular guy is not supposed to snore. So breathing is supposed to be a noiseless phenomenon. Now, if I have to whistle, can I whistle with an open mouth? No, I can't, right? If I have to whistle, I have to create a pursed lip breathing, I have to create a turbulence, I have to create an obstruction. So if there is sound, there has to be some obstruction. We have all known about striders. all seen kids with breathing difficulty. The sound is what alerts us there is something wrong. Now what happens in normal sleep? Now just focus on the area behind the tongue, that is our airway, and say that's 100 units cross-sectional space when the patient is awake, alert. During sleep there will be some hypotonia, we agree with that, and the tongue being muscular organ will drop back and the area will reduce to 70. Still the person will maintain normal oxygen levels, normal heart levels, there will be no sound. No doubt there, that's how we sleep. Now what happens in an OSA patient is they have a crowded upper airway. The ENT doctor's job here is to find out where that crowding is appearing, where that abnormality is appearing, whether it is a hypertrophic tongue, whether it is a nasal fossa which is responsible, soft palate, hypertrophic tonsils, or the fatty tissue just around the airway which is causing is, there is some obstruction at play already happening. So when you see this guy who's got a compromised airway, during the day it is 70, which is not so bad, which is what we have in our sleep. However, there is a 30% drop because of the loss of tone in the night, which reduces the cross-sectional area and crosses the threshold. So say 50 is the threshold beyond which the sound will start. I'm not worried about a guy who's at 49 and he's just what we call as a primary snorer. My worry is a guy who's at 40, 30, 10 and 0. So what will happen? Naturally, instead of 100, he has only 40, so he'll have fallen oxygen levels, he'll have increased heart rate. If somebody is sleeping and if I place a pillow on his face, what is going to happen? Is he continue to go to sleep? No. He is going to have an arousal. So these are micro arousals which are happening during sleep, where the patient goes from stage 2 sleep to wake state again. But this event is not registered by that patient. It's not consciously registered by that patient. The airway gets resumed, the brain says it is time to go to sleep, oxygen level normalizes, heart rate normalizes, brain goes back to sleep, and what is going to happen again? The same cycle is repeating hundreds and hundreds of times during the night. And the guy is sleeping for 8 hours, but he's just not able to reach deep sleep. He reaches stage 2 sleep, he sleeps and he's like, I was sleeping the whole night, but I don't feel fresh in the morning. Okay, and what is happening? We are having a fragmented sleep. So instead of getting this wonderful natural sleep with lots of slow wave sleep, that is how the sleep that person is having with absolutely no stage 3 sleep. So how that person is going to feel? He's going to feel irritated, he's going to feel sleepy, he's going to have a lot of challenges during the day. And this is not only a problem of a Kumkaran kind of a supine obese patient. Research has shown time and again that more than 50% of patients with sleep apnea are non-obese. Okay, and there are other factors also which guide in terms of which patient transitions into sleep apnea, not transition to sleep apnea. I'll not go into the details, but there are essentially two phenomena happening. One is the sleep fragmentation, which leads to all the neurocognitive symptoms. So you will have brain fog. How will you going to feel if you are not going to sleep 4 days in a row? I don't think anybody of us will like sitting in the clinic listening to the patient, because we'll have brain fog. But the more important thing from the cardiac perspective, and if you don't want Dr. Manish Gar to do that surgery on you, is to avoid the intermittent hypoxemia. That is what the person is having. That is what the person is at risk at. 3 times more incidence of stroke in untreated sleep apnea, 3 times incidence of drug-resistant hypertension, 3 times incidence of all metabolic parameters, and compare that to the population that is there. And it is not just an adult obese problem. We have seen it in 2-year-old kids, we have seen it in 3-year-old kids. You label them as ADHD, you label them as poor growth, and this is what you get is a truly multisystemic disorder. So we just need to open our eyes for the condition that is there. In kids, the studies have stated 6 to 8% general population incidence. So busy pediatricians here in the audience, you will be seeing at least 2 or 3 kids, maybe perhaps more, every day in your clinic. And what are the symptoms? Symptoms are very vague. We may label them, they are the daily symptoms. They get labeled as, now the new thing is the long COVID syndrome, where patients are coming and a lot of them are undiagnosed sleep apnea. And you will have a patient who's snoring, gasping, witnessed, and these patients can even present with insomnia. That is a take-home message. Generally, I will ask for the bed partner to be around because they can describe the apneic spells better. But it's very straightforward. Most of these patients will have snoring, most of them, but only about 50% will complain of a poor quality sleep. not everybody registers sleep fragmentation to the same extent. So it is not that if the person is not feeling sleepy in the morning, if he is feeling fresh, he is not having sleep apnea. So less than 50% will actually have neurocognitive issues, and children, like we discussed, get labeled as ADHD, but that is what we need to screen for. A simple scale in the clinic can tell us and help us objectify the sleep parameters. We define the excessive sleepiness using the Epworth sleepiness scales, where we use a 3-point kind of a scale to find out where routine activities. So simple question that I ask, आप सुबह संडे मॉर्निंग को अच्छी नींद निकाल के उठते हो, 11 बजे जब न्यूज़पेपर पढ़ते हो तो तब भी नींद आती है क्या? If you have got good sleep, and if he says yes, then that's a red flag. Do you want a nap every time after lunch? Yes, that's a red flag, and that the question is very specific after getting good 8 hours of sleep. There are patients who will doze off, there are doctors who will doze off while operating. And I've had those patients. There are doctors young who will kind of like feel sleepy even after 10-12 hours of sleep, and they are not feeling fresh, and that's sleep apnea for you. Okay, so we try to grade it and we find out. But what is more important for us is to find out where that obstruction is. A simple awake fiber optic examination tells us that answer within 5 minutes, less than 5 minutes. It's a simple clinic exam where I can identify what are the level. More common than not, we find multiple levels of block. He may have an obstructed nose, inferior turbinate hypertrophy, may have large adenoids. We have seen routinely 25, 30-year-olds with adenoids, 40-year-olds with adenoids, which were typically should have resolved but don't resolve. And we look for simple things like the nasal valve collapse. We look for a deviated septum. Sometimes we may go ahead and do a CT scan to look out the extent of the problem. And just look for a crowded airway. This is something that everybody can do in the clinic. Just look for the tongue size. Just look for this kind of a sign. If he opens his mouth and you're not able to see anything beyond the tongue, you're not able to see the uvula, this guy has a high risk of having sleep apnea. You look at their tonsils. It's something that you can do in less than 30 seconds. Again, crowded upper airway, high risk of sleep apnea. So you get a guy who's snoring, who's got hypertension, not feeling fit, just make him open his mouth, just put a torch inside and just have a look. You don't need any special gadgets for this, and just screen them out. So my today's message is essentially this. I'm sure, Ajit, have you circulated all of these forms? So this is something that I would request you to do. It's a very simple thing, scientifically validated, been around for decades, a workhorse in the busy clinic, is you ask this simple questionnaire that stop, that's for snoring, tiredness, observed apneas, pressure issues, and the band. BMI more than 35, age more than 50, neck circumference more than 40 centimeters, and a male gender. So if more than 3 are positive, so you get a 50-year-old guy who's come with pressure issues, who's snoring and feels tired, bang, very high risk for sleep apnea. And I'm sure we are seeing at least 2 of these patients every day in our clinic. This is not an uncommon kind of a presentation. There are other recommendations for screening also. Patients with resistant hypertension, pulmonary hypertension, recurrent atrial fibrillation, or with any kind of heart failure, if you find sleep apnea symptoms are there. And also the recent Indian guidelines from diabetes mellitus tells us that we should be proactive in our screening, and what they suggest is that these things go hand in hand. They are part of the metabolic syndrome. So if you find patients with diabetes mellitus with other cardiovascular risk factors, please screen them for sleep apnea and order a sleep study. It's a very simple tool to order. And a level 3 sleep study. 95% of my patients get ordered a home sleep study. This is validated by the American Academy. This is not shortcut. This is standard of care. So you can order a home sleep study very easily. It's not that heavy on the pocket. And typically what's a level 1 sleep study is where we do maximum assessment, right from EEG, EMG, to the flow meters, to the oxygen sensors. However, reserved for challenging patients. However, this is our workhorse. Level 3 is our workhorse, which is a simple home-based sleep study. The patient can sleep with the comfort of his home. In COVID era, he doesn't need to come into the hospital. It can be done at his own bed, and it is very non-invasive. So this is a picture that you get after level 1 sleep study. Very complicated montage. I'm an ENT guy, remember how difficult it must be for me to interpret, but this is very simple to understand. You just focus on this point here. Can you see the flow getting obstructed here? And just look at the EEG after that. How are you seeing the waveform? So after every flow, you are getting an arousal documented in the sleep study. This is something a level 1 sleep study takes about 3 to 4 hours to score. The technicians literally sit with it and score every event, and they come out with certain parameters. So what is apnea? Apnea is very simple. We know that. Complete cessation of airflow. Hypopneas are the ones where require additional effort and where there is partial reduction of airflow. So typically a lot of us don't require a complete obstruction in the airflow to disrupt our sleep. Our sensors are very alert, especially if we are on the younger side of things. Even partial obstructions can cause an arousal. And all these apneas are calculated and divided by the sleep time. So that's the baseline score. That is your random blood sugar that you get. That is your fasting blood sugar that you get when you're comparing that with another chronic condition called diabetes, which we are very familiar. It's AHI. You read any literature on it, they'll talk about AHI. That's the benchmark about sleep apnea. And to label as sleep apnea, I need more than 15 events happening every hour. So that's close to, if I have a 7-hour sleep, if I have an 8-hour sleep, that's close to 100 events in the night. And imagine he is obstructing 100 times throughout the night. That's a big number by itself, right? Who's going to feel fresh after that? Or if the person is symptomatic, then more than 5 events per hour. Now severity is very simple. 5 to 15 is mild, 15 to 30 is moderate, and more than 30 is severe. And that's how a sleep study looks like. Okay, first I need to determine lots of numbers, but you don't need to know about all the numbers. You just need to look for, okay, whether it was done in the lab. When there is a lab sleep study, you will get EEG data. When you are not getting, you are getting only oxygen data. That's a level 3 study, that's a home-based sleep study. And you focus on the one number that is there, that is AHI. So that's 93.6 per hour. So that's like less than 1 minute between 2 spells. You imagine the number of spells that person is having. Look at the positional data. Typically, the non-supine position data, when the person is sleeping on the lateral position, naturally the obstructions will be less. And look at the oxygen variables. His saturation is dropping down to 79% in the night. His ODI is 66 times every hour. There is so much of intermittent hypoxemia happening. He is spending more than 24 minutes in the night. So if I get a person who's got more than 11 minutes in the night, he is at 11 times higher risk of an adverse cardiac event anytime in the near future, because he's going to have these sudden fluctuations in his oxygen levels, and he may have, and that is perhaps one of the most common reasons to have that early morning stroke, that wake up stroke, one of the common reasons to have that early morning myocardial infarction or the acute MI. And we look at also the hypnogram to look at the quality of the sleep studies, and you can see the multiple drops that are happening in the saturation level. This black line is the saturation levels, and essentially this tells me whether how good quality the study is. If I am getting a recording throughout the night, then I know that my sensors are not fallen off and we have got a good quality data. Now treatment options Dr. Kinjal will be discussing. So very easy thing to order a sleep study. My only message through the day would be just get, I mean if you want we can share more copies of this top bank questionnaire. Just try screening this patient. If you just spend 5 minutes with this patient, you will be able to identify much better, and sleep study is something that can be ordered very easily. Okay, multiple treatment options, the benchmark being the positive airway pressure therapy. There are assistive measures like a surgery, oral appliance. If there is an upper airway obstruction which is surgical correctable, then surgery becomes the first treatment of choice. Or a lot of times we do a combination of surgery followed by CPAP, and then there are other exercises that can be done, positional free therapy, and there is an emerging role of drugs coming up. So with that short talk, I'll be inviting Dr. Kinjal to take over, and then we can have a small discussion once Dr. Kinjal has done with his presentation. Thank you so much.
Thank you, Dr. Rahul Modi, for your elaborative talk on sleep apnea. Let's welcome Dr. Kinjal Modi for further line of treatment.
Namaskar. I hope you are enjoying your stay in Gulmarg and KHANVEL resorts and this educational feast by BMB. I am Dr. Kinjal Modi, consultant chest physician from Hindu Hospital Khar and Mesans of Mumbai. I have done my post-graduation from Naya Hospital and fellowships from American College of Chest Physician and Hermes Diplomat from European Respiratory Society. I have special interest in asthma, COPD, lung cancers, TB and critical care medicine. Being trained in Western Zone's first sleep labs of private and public setup, I have special interest in sleep apnea and I am going to speak on the same topic today. Thank you. Hello, very good morning to all of you. So after learning how to diagnose OSA, which Rahul had nicely described all of you, I would come to the treatment part of it. So, regards from Kinjal. Basic to start with, can we do something apart from medicines and everything? So that is possible, yeah. There is behavior therapy. We don't want a body on the right hand side. We always want a body on the left hand side. Everyone agrees to that. So sleeping in a supine position can be avoided simply. Alcohol and smoking definitely can be avoided. Surgery definitely has some role, but if you can understand one simple thing is, historically tracheostomy was considered to be cure of OSA. If you do a tracheostomy in a patient is cured of OSA. Perfect answer. But is it possible? Answer is no. So before going for any surgery, we always have to understand as a clinical person when to go for it and when not to go for it is more important. So going ahead, basically, what are the things we should understand? Sorry. So severity, basically, it's the OSA, with COVID condition, it will be there, severe symptoms, and the anatomical obstructions there, simple indications. But when not to go for it, morbid comorbidity, when there is a severe unstable cardiopulmonary disease, alcohol and drug abuse is not going to go away, older age and psychological problems. What are the different kind of surgeries? I told tracheostomy, as you understand. Next is triple P. It's a very nice surgery which was used last decade ago very rapidly. And still, for the medical purpose, still they put it on paper. But it's not very effective nowadays. The reasons I'll tell you in some time. Reconstructive surgeries, mandibular surgeries, everything is very upcoming, and our Naya Dental and other people are doing very nicely. Laser palatoplasty, palatal implants, and radiofrequency ablations are also options available for surgery. Putting all these things together, generally when we ask the patient to go for surgery, few indications are even given. We ask the patient to be on a CPAP therapy for some days before the surgery. We ask them to have a trial to see how extent the disease is getting controlled. And if it is more than, OSA is more than 40 with nocturnal desaturation, preoperative CPAP is definitely indicated in this kind of patient. So, coming to that, those things, all the treatment modalities from surgical aspect, if I tell you, are they very effective? There is a forest chart on my left hand side. So, if this forest chart is a very busy slide, but if you understand, very simple thing to understand forest chart, if you don't know anything about it, if all those diamonds, if they touch the line 0, the treatment is not effective. Simple thing to understand. If it touches 0, therapy is not effective. If you see, all the things are touching 0. So what does it mean is, there is no significant effect on daytime sleepiness or quality of life with all the surgeries what I told before. The AHI and snoring are reduced in some UPP surgeries, definitely. But the subjective snoring are reduced, we can say. And the persistent side effects definitely are there with these kind of surgeries, which are very difficult to handle later on. So, in one sentence, surgery are not always effective, except in few indicated cases. So, going ahead. So, what is always indicated? It is positive airway pressure therapy. What does this mean? What is the basics of PAP? I want the answer from you, so I'll make you awake. What is this? Can anyone answer this? I have a category for this. Pardon? Kinjal log bol gaye, chalo theek hai. So police fracture, fantastic. Thank you. So treatment kya? Treatment kya? Reduction. Okay. Anything else? Aage. Blast. Fantastic. What I want an answer. Thank you. So plastering. Generally surgery is only close reduction and fixation. That is what we do. Plastering. So that is what is required. So the splint basically comes over there. Same fundamental using over here. That is the basic principle of OSA. So it's easy to understand. So what we do, it creates a pneumatic splint in our upper airway. What Rahul told, there is obstruction, ye, blah, 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 30%, 40%, exactly fine. But treatment, hold those, काम करता. And can he go inside and open it? Every time not possible. Surgery, as I told you, is not always the option. So what else can be done? Put a splint over there at least. So that is a pneumatic splint. So it works wonderfully. Snoring चला गया, सारी effects जो डॉक्टर राहुल ने बताया अभी सारे वो चले गए. So the patient is happy, sleep अच्छा आएगा, सुबह freshness, EPP score उसका था, upper sleepiness score will come down. So things are settled with this. Okay. So going further, just to underline the same thing what I was telling is, normal open airway looks like this, partially closed with the snoring part and obstructed, that is the apnea part, looks like this. Well, Dr. Rahul will cover. So I go ahead. This is a busy slide, but there is a whole thrust of my further slide what I am going to go ahead. So what is this saying? We first have to clinically diagnose, sorry for that fine print, the first one, I will not be able to read it, I just tell you in a brief. So clinically we have to diagnose a patient, either he falls in some kind of OSA, snoring effect, apperceptiveness scale and all this clinical diagnosis is done, fantastic. Patient falls in the OSA criteria, go for a sleep study, assess it, if it is significant positive, give a CPAP trial. CPAP trial, later there's a troubleshooting problem, there's a problem, so troubleshooting everything is there, so follow up and everything are very important. So this is a 4-5 slides which I'm going to cover in my further talk. Coming to it, so basically positive airway pressure is a pneumatic support, pneumatic splint we can say. Maintaining a pressure is very critical, so that is very important. That is how pressure is connected and how pressure is built. It's something like interface. If you see the stall over there, they are showing the interface. The masks are there. There is an oral nasal mask, there is a nasal mask, there is a nasal pillows. All these things are available nowadays. So virtues we have even and the hood and all those things were used earlier days. But all these things, sophisticated interfaces are available nowadays to create a pressure. And which are only thing is the more facility you take, the pressure generally goes on lower side. So it is highest with oronasal mask and lowest with pillows. But the what we call comfort is more with the is a reverse way around. So comfort is more with the pillows. That is what we can understand. Next is the pressure applied varies with the severity, obviously, and that how it is calculated we will see in the next slide. And higher pressure is generally required. Okay. So different type of CPAPs. You must have heard there are different machines. You have seen this machine, fine. But same machine are available in different kind of variations. So that is a bit confusion in our mind. So basically what is there? Let's see it one by one. It is CPAP, continuous positive airway pressure. So there is a one line, one pressure throughout the night. If a patient applied, there only one pressure. 8 to 8, 10 to 10, khatam. Aage piche kuch nahi hoga. Next is auto CPAP or auto set CPAP we can say. The pressure changes according to need. आपको 10 चाहिए, machine 10 देगा. आपको 12 चाहिए, machine 12 देगा. आपको 8 चाहिए, machine 8 देगा. The variation will be there according to resistance of the upper airway. And next is bi-level. Expiration में अलग, inspiration में अलग. BiPAP what we use, that is bi-level ventilation. Right. So going one by one, fixed. But problem is, एक pressure नहीं चलता ना. Unfortunately, as a blood pressure, pulse, they are varying. So we don't have a particular pressure also upper airway. They change. So giving a fixed pressure, we can titrate what pressure is required and give it. This is an economically good option. But if you are physiologically, thoda sa difficult है because the thing is, if we cannot give a proper pressure depending on the variation, patient might not accept it nicely. Next comes is automatic one, as I told you, fantastic use, positional use, whatever thing the patient can be using it, it is giving a better acceptability because the pressure changes according to what patient needs. So very good. So we have not a fixed pressure opposed to the continuous pressure, and upper airway basically is nicely managed with automatically. And so obviously it is pressure identification, there is variation, there is positional REM related OS also current, and pediatric patient also very happy with this. How pressure things are collected? Basically, they are derived titration study, we find it out, and according to the percentile, depending on the we advise the patient to have the pressures. Bi-level, BiPAP, expiration, because when we breathe, we have to breathe against both the positive air pressure, we give a continuous airflow. We cannot breathe out through that. So bi-level ventilation is a one thing in which patient breathes out, expiration pressure is low, inspiration pressure is high. But are they indicated for all OSA? No. OLS syndromes. OHS. The other two basic indication, OLS syndrome is OSA with the airway disease. OHS is hypoventilation syndrome. So these are the people who are definitely indicated to have a bi-level ventilation. Nice. After we prescribe, there are few things we have to understand that there are ट्रबल शूटिंग, पेशेंट को मजा नहीं आया, क्या करने का, कैसे करने का. So all those things are put in a busy slide. So which have each and everything can be evaluated very nicely and can be addressed very nicely. I'm not going into details in the interest of time. But everything of the patient, what patient question asked to you, कितना time लेने का, कब लगाने का, कब निकालने का, क्यों करने का, सबका studies हो चुका है. It can be easily, many of our patients are definitely there on treatment for many years. So, for improving compliance, there are few things. Patient education, to educate them very nicely, where your role comes in. The positive pressure treatment, proper treatment has to be given, mask, humidification and telemonitoring. If you monitor a patient yourself, patient has confidence, कोई देख रहा है, somebody is monitoring me. So that basically increases 72% of compliance. Very good for us. How it works? Just a minute again. Basically, it's connected device to the air sense. There is basically an air leak and air view machines available nowadays. It's cloud related. So telemonitoring can be easily available and patient is monitored by a physician himself. Fine. And this kind of charts are coming to the physician also, that they can check the patient is basically having the proper quality of the CPAP pressure is given or not. You have the red marks and the green marks over there. The green is proper, red is bit of the not a proper. So basically to ask the patient what the issues were. So now, I don't want to give take home message. I want to give take to clinic messages, because घर पे लेके जाकर लोग सब सो जाने वाले. So I want, when you go to a clinic, just remember few things. Think of OSA in all snorers. Next is do a baseline workup at least for all of them. And last but not the least, help in compliance with the device. There's only 3 things are required out of you, not more than that. Diagnosing कितना pressure क्या है, send me to me, Dr. Rahul, anyone else you want, वो हम लोग manage कर लेंगे. But basic question, people come back to you and ask basic questions to you. That should be clear.
Hello, sorry to interrupt Dr. Kinjal.
Madam,
Time is up.
Thank you. If you have any questions, me and Dr. Rahul are here. You can definitely ask.
Any question from the audience? Yeah, please. Please, ma'am, you can ask.
Mike over there.
Meanwhile, I just want to ask, all sleep apnea, like all snoring is counted as sleep apnea? Because many a times patient complain that I get snoring. I get snoring when I am very tired physically. Otherwise, my sleep is okay. So
see, all snorings are basically not OSMR. Basically, you got to understand that if snoring associated with desaturation, Dr. Rahul has clearly told you, if there is associated desaturation, then only we can address it. That is an important take-home message. Also, you would consider that. Anything to add?
So essentially, we look at what we are treating here. Okay, so I would be worried if this person who's snoring has drug-resistant hypertension. I would be worried. Then I would like to screen him with a sleep apnea or a sleep study. So screening is very important using a stop-line questionnaire, where we can highlight whether these guys are good candidates enough for sleep study. So if he is more than 50 years of age, if his BMI is on the higher side, along with snoring, then I will like to screen him for sleep apnea and order a sleep study. But if he is a 25-year-old college goer who will snore once a week, occasionally when he's too tired, then I'm not going to lose my sleep over it. So just that. So we need to know there are 3 reasons why we treat sleep apnea. One is the snoring is so loud that the bed partner cannot sleep in the same room. That's a social reason. Second is the person is having neurocognitive issues. He is finding it difficult to stay fresh during the day. And third, he has got severe, significant cardiovascular morbidity. These are our 3 main targets of treatment. And beyond that, we look for if the person is at risk for serious sleep apnea.
thank you, Dr. Rao.
Can I ask a question?
Yes, please.
This question is for Dr. Rahul. There are some patients who report some relief from snoring after the yoga breathing, meaning if they practice pranayama. Now, I believe it may not really take away the upper airway obstruction. Do we have any data, any studies?
Yes. So we are insisting a lot of things nowadays. So I showed in the slide something known as myofunctional therapy. I actively counsel each and every patient of mine. I give them a YouTube video link. That these are the exercises. I have so many patients who have felt better with Kapalbhati, with Anulom Vilom.
Can you just enlighten in what way will it work?
So basically, there is so the snorer is not snoring when he's sleeping, when he's during the day, right? So what is happening? He's got poor tongue muscle tone. He's got poor upper airway tone. How do you improve that tone? I showed you 2 slides of crowded oropharynx. One was a large tongue and one was a large tonsil. which will respond to exercise and which would respond to surgery? Common sense. I cannot knock off somebody's tongue, right? I have to improve that. It's a muscular organ. But if it is a large tonsil which is crowding, then this guy may not even tolerate the CPAP. I have to actually surgically go and exercise. So it has to be personalized. One size fit all therapy will fail miserably in CPAP. What is the success rate of, say, any therapy? In isolation, not more than 50%. In compliance data, you take CPAP, you take surgery, but we have to go for combination. So exercises forms an important additional adjuvant for all. So as I improve my tongue muscle tone, my tongue will not fall. So now answer data, just by exercises, more than 3 months, we can get more than 50% reduction in that AHI number that I showed. Proven review, proven literature, beyond doubt. So exercise forms a very significant part of therapy, yes.
Thank you.
Thank you, Dr. Rahul Modi and Dr. Kinjal Modi for your nice presentation.
Oral medication.
So there are some trials going on, sir, but none yet. We are using some sleep stabilizers, but that is still not out of the experimental realm. So no FDA approval, no guideline approval so far for those medications.
Great. A big round of applause. When one Modi speaks in Mann Ki Baat, each word enters our mind and heart. We have 2 Modis today, so definitely everything has to go in our brain. Thank you both the Modis for giving an awakening debate and a lecture on the important subject of sleep apnea. I would request our moderator, Dr. Alpa Mehta, to felicitate both the speakers, Dr. Rahul Modi and Dr. Kinjal Modi. A big round of applause for them.
Our moderator, I request our organizing chairman, Dr. Pratik Jariwala, to do the honors.
Dr. Pratik. Co-chairman.
Yeah, our co-chairman,
Dr. Ganesh.
Dr. Ganesh Shenoy. So please come on the dais to felicitate our moderators.
On behalf of the chairman, Dr. Pratik Jariwala.
A round of applause. And now I call on stage the moderator of our next session, Dr. Sanjay Trivedi sir and Dr. Nitin Divde sir.